A patient diets, loses weight, and regains it. This cycle persists because lifestyle counseling alone cannot override the underlying biology of the disease. Weight was framed as a behavioral failing, reducing a complex physiological state to a simple physical metric. The updated VA and DoD clinical practice guidelines reject this behavioral model. Obesity is classified as a chronic, relapsing, multifactorial neurobehavioral disease. Effectively managing it requires clinicians to look past willpower and treat the underlying physiological dysfunction. Body mass index remains the primary screening tool for this disease because it is scalable. However, it lacks the precision required for individual diagnosis. BMI cannot differentiate between lean muscle mass, subcutaneous fat, and dangerous visceral adiposity. Two patients with the exact same height and weight can present entirely different metabolic risk profiles based strictly on where their adipose tissue is stored. To identify high-risk metabolic phenotypes, clinicians must integrate specific anthropometric measurements, like waist circumference, directly into the primary care workflow. Prioritizing advanced body composition allows clinicians to identify actual tissue dysfunction, shifting the diagnostic focus from total mass to metabolic risk. When a patient begins caloric restriction, the body interprets the deficit as a threat to survival. It initiates a rapid compensatory hormonal shift to actively defend its existing fat mass. The hunger-promoting hormone ghrelin surges. Simultaneously, satiety hormones, leptin, peptide YY, and GLP-1 precipitously drop. The patient becomes intensely hungry, while their neurological threshold for fullness increases. To conserve energy, the body triggers adaptive thermogenesis. Resting and total energy expenditure decline disproportionately to the loss of body mass, lowering the metabolic rate. This altered physiological state actively promotes weight regain. The patient's own biology resists the clinician's prescribed caloric deficit. Because these systems operate on survival-level neurobiology, a standard eat less, move more recommendation frequently triggers a biological stalemate. The problem extends beyond energy regulation. Excess adipose tissue eventually reaches a physiological tipping point known as adiposoliphy, where it becomes highly dysfunctional. Visceral adipose tissue effectively transforms into a highly active, rogue endocrine organ. This dysfunctional tissue continuously secretes endocrine factors and inflammatory cytokines. This cascade drives chronic inflammation, leading directly to insulin resistance, dyslipidemia, and cardiovascular disease. Until this adiposopathy is treated at the cellular and hormonal level, the compounding systemic comorbidities will continuously relapse. Nutritional biochemistry determines how the body processes incoming calories. Specific dietary molecular structures interact directly with these neuroendocrine defense mechanisms. This chart tracks blood glucose over time. Line A demonstrates the digestion of natural sugars. Because they are processed alongside natural fiber, they produce a slow, gentle rise and a stable, prolonged blood glucose plateau. Line B shows the digestion of added sugars. Their volatile processing creates a sharp, rapid spike in blood glucose, and the excess energy is quickly shunted directly to the liver for immediate fat storage. What follows is the glycemic crash. The blood glucose level plummets below the baseline, significantly lower than before the patient ate. This severe drop triggers the exact starvation signals discussed earlier, driving intense cravings and prompting overconsumption. Added sugars act as potent molecular triggers, actively weaponizing the body's neuroendocrine defenses against the patient. Before prescribing dietary interventions, clinicians must evaluate their own prescribing habits. Standard pharmacological treatments for co-occurring conditions often actively sabotage a patient's weight loss. The most severe pharmacological culprits driving weight gain are atypical antipsychotics, particularly medications like olanzapine and clonazepine. In primary care, the routine prescribing of common antidepressants like mirtazapine and specific SSRIs like paroxetine frequently compounds the physiological drive to accumulate fat. Clinicians can remove these pharmacological barriers by conducting a rigorous medication audit, swapping weight-promoting drugs for weight-neutral or weight loss alternatives. The VA and DoD guidelines recommend specific replacements, such as switching to bupropion for depression, or leveraging GLP-1 agonists for indicated metabolic conditions like type 2 diabetes. A comprehensive weight management intervention requires removing these iatrogenic barriers. Otherwise, the physician and the patient are working at cross purposes. Managing a highly stigmatized disease requires a standardized, non-judgmental framework for patient encounters. This is the 5 A's framework, a structured communication solution. It organizes the encounter into 5 steps: ask, assess, advise, agree, and assist or arrange. The ask and assess phases dictate permission-based communication. The clinician evaluates both the patient's adiposity and their readiness to change before prescribing an intervention. Advise and agree shift the clinical posture from imposing strict dietary mandates to engaging in shared, personalized decision-making based on the patient's specific health risks and values. The 5 A's framework operates as a clinical standard that aligns obesity care with established principles of chronic disease management. Due to the persistence of metabolic adaptation and adiposopathy, isolated behavioral interventions are biologically unlikely to achieve long-term weight reduction. Comprehensive lifestyle interventions remain the foundational baseline for all treatments, but they are strictly the first step. Effectively fighting neuroendocrine resistance requires concurrent medical intervention, specifically through targeted pharmacotherapy or metabolic and bariatric surgery. With weight-related issues now disqualifying more potential recruits than any other single. Achieving clinical efficacy demands that the medical community abandon the stigma of behavioral failure. Obesity is a chronic pathophysiology requiring lifelong, multimodal medical management.